All right, everybody, welcome. We have a absolutely phenomenal, exciting workshop, panel discussion, and conversation with three phenomenal embodiments of who OCAMPR is. We have Dr. Jim DuBois, who we, at least I, clapped for a lot for being the new editor for Synergia, the OCAMPR journal. He's got extensive research, writing, teaching experience. He's the S.J. Bander Professor of Medical Ethics and the Director of the Bioethics Research Center at WashU. And this is a tremendous opportunity for us to learn with him, from him, and discuss together. He's joined by Dr. Sarah Byrne-Martelli, who's a board-certified chaplain and acute care and hospice. She's been doing this since 2002. For those of you doing the math, that's 23 years of professional experience and counting. And she has an excellent book that we should all be benefiting from and reading, Memory Eternal, Living with Grief as Orthodox Christians. This was published by Ancient Faith in 2022, 3 years ago. And right now she's a research fellow at Dana-Farber. She's one of my personal heroes and a good friend on the OCAMPR board. And our trifecta is brought to completion with Dr. Casey Clardy, who is a licensed clinical psychologist committed to reducing health disparities in under-resourced communities of color. She's been doing this for 13 years and counting at the Lonsdale Christian Health Center, a faith-based community center on Chicago's west side. I think a big reason that we do the conference here every year is to make it convenient for Casey to come. She's a perennial attendant here. And I'll be advocating with Randa to continue doing the conference in Chicago so Casey can join us. So thank you all three in advance.
Yeah, the agenda today, I'm going to speak for just about 15 minutes generally on this topic of peacemaking in clinical encounters during times of culture war. It's a mouthful, but I think it's timely. And after that, we've asked Sarah and Casey to take turns presenting cases that illustrate engagement with things that are socially divisive and looking at concrete strategies for doing this in a peaceful manner. I want to start by acknowledging, actually, in the West today, it is the feast of St. Francis of Assisi. So it's such a beautiful day for speaking on this topic. I've noticed something among young people today. There's an old saying, hate the sin, love the sinner. I've noticed a lot of people think you can't do that. You can't do that. And I say to myself, why? It seems so obvious to me that you can. And I think some of it is that Christians aren't doing a good job in the public sector talking about things they view as sin in a loving way, right? We see the policy issue, we see the political divide, but we lose sight of the people who are behind that, and they're often people who are suffering. So the culture wars, that term was coined in the early 90s. And, you're all familiar with them, right? Where we see two deeply entrenched sides viewing the other as the enemy on social issues. And when James Davison Hunter first characterized this, he was focused on issues of gay marriage and abortion, how children are educated. I think these still continue to be contentious, but today the issues have shifted a bit more. I think transgender care, vaccines have come much more to the fore since that time. And also, interestingly, at that time, it was viewed as largely a tension between conservative religious people and secular society. That continues to be true, but I think we also witness the culture wars within communities, right? I think even within the Orthodox community, we feel the tensions between warring camps. So healthcare, the field I work in the field of bioethics. I work at a medical school, a large secular medical school. And, this is the ground right now for so many of the culture wars, right? I've already mentioned a few of them, but in addition to that, physician-assisted suicide, even something as simple as universal healthcare access as a goal, because that usually is viewed as requiring the government to be involved, it becomes highly controversial, right? So why do people typically fight wars? Why do we become combative or aggressive? I think it's typically because we're perceiving a threat to ourselves, to our family, to our countries, to our values, who we see ourselves to be. In the case of healthcare, if you look at just a few of these very divisive issues, I've listed here just some of the threats that people feel. Some of these are psychological, right? When someone starts talking about the other and are making hostile comments, people can feel unsafe. Others feel that their personal integrity is challenged, compromised when they compromise their principles or appear to be, right? Some people feel that even being silent in a debate is consenting to the other position and that their integrity is threatened, right? People feel that they're losing rights, right? Whether it's rights to healthcare services, rights to conscientiously object. And we see, depending on what administration is in power, the threats are often completely opposite. We just saw a huge pendulum swing from Biden to Trump, and who knows what we'll see next. Loss of ability to raise kids according to your own values, certain behaviors being criminalized, and sometimes even the same behaviors, Could you be, as a parent, accused of abuse if you provide transgender care for a kid? What if you don't? Could that be criminalized? Of course, depending on the administration either. With vaccines, we see people worried about failure to achieve herd immunity, threats of diseases. With abortion, we have people worried about death of the fetus, others worried about potential loss of life of mothers who need emergency treatments. And finally, as we've seen just too recently, shootings, violence, where the culture war shifts from just words to physical violence. So, and we see it playing out in every domain of our life. Most commonly we see it in social media, which I really try to avoid. We see it in political campaigns, the education system, in our legislative bodies, but also in clinical encounters. And that's really what we're going to focus on today, is peacemaking. How do we deal with these culture wars when they come to us in the clinical setting? And I'll say these cases just scratch the surface. We're hoping to leave at least 10 minutes at the end for discussion where you could bring your cases as well. But hopefully we're just priming thinking and starting a dialogue today. This is an interesting chart from a book, The Peacemaker, that really highlights just different ways of responding to conflict. And I think the middle zone is that sweet zone there, avoiding the extremes of escapism and of attack. I want to be really clear. What I'm not saying today is that the Orthodox Christian position requires people to be passive. I don't think that's true at all. I think we need to be engaged in the world, but engaged in a certain way, in a non-attacking, non-combative way. This seems to me just so patently clear in the scriptures that this is the way we're supposed to be engaging the world. The Sermon on the Mount, the Sermon on the Plain, very few people take this seriously. It is such a challenging ethic. It is so challenging. Here, this an eye for an eye, a tooth for the tooth, this was the old, law. But instead, Jesus is saying, whoever slaps you on the right cheek, turn your left, right? As a young man, I always wondered, do I turn my cheek before or after I hit him back, right? You know, it's so unnatural. It's so unnatural. Love your enemies. Do good to those who hate you. How hard is that? This is a really... we talked yesterday, we heard, are certain things, is deification a natural capacity? I would say this is a deified response. This is not a natural capacity of ours, right? So this is a very hard ethic that we're talking about. St. Basil makes it clear, yes, we're in combat, but we're in combat against the demons, against logismi. We're in combat, not against each other. Don't hate the person who does evil to you. They're not ultimately the evil that's behind the act. Elder Thaddeus, I think many of you know, this is our modern day Orthodox cognitive psychologist. He's just amazing. And really what you see is that his theology of our thoughts is so powerful. He talks about our thoughts. I mean, the title of the book says it all. Our thoughts determine our lives. They shape our interactions with others. People pick up on what we're thinking, even if we don't vocalize it, right? It has an impact on them. And what you really see in his book is this sense that you will not be able to have positive relationships and be this peaceful, loving presence to others except through prayer, except through inner conversion. So this is really not, this is where it's very different, I think, from cognitive psychology. He's not preaching a certain sort of self-discipline or an ethic of behavior per se, but truly a conversion of heart, really working on yourself so that you can be that peaceful presence. Here, I want to just also acknowledge, one of our own participants in the conference today is Deacon Perry Hamalis. He's edited and written chapters in a really good book, Orthodox Perspectives on War. He's talking about actual wars, combats. Some of it's really fascinating, though, where I think we can draw analogies even to culture wars. And it challenges us not to be complacent. We should be engaged, right? But I think any theology of war would have to teach, even if you needed to justify armed conflict, you still, even then, can't justify hating the other person, right? That's, again, kind of mind-boggling that you might need to take up arms, but without hate, right? And so that's really what I'm trying to say here, is not defending inaction, but rather defending non-combativeness and remaining loving even as we're doing what we need to do. So there are a couple of concepts here that I'm just going to ask you to kind of keep in the back of your mind as we turn to the cases. There's a word we've talked about already, during this weekend, the fact that not all of our Greek terms have good translations into English. Apatheia is certainly one of them, right? Maybe best translated as passionlessness, but it's certainly not the English apathy, right? And so how do we pull this ancient sense of passionlessness into our engagement with socially divisive issues while leaving the U.S. American English sense of apathy behind? We should never have the apathy. That's a lack of care, right? So how do we balance, though, this passionlessness with the obligation to serve and to be leaven to the world, to pray, thy kingdom come on earth as it is in heaven? And we're also, through the cases, going to explore not just the theology of peacemaking, but concrete strategies. And I think this is where, Sarah and Casey have some really neat things to share with us. And I've got a slide that ties some of it together at the end as we head into discussion. So I'm going to turn it over to Sarah right now.
Thank you. I have some extra here. Can I hold this? Okay.
Thanks, sir.
Hi, everyone. Okay, don't get too focused on reading everything first, but I just want to say a little bit of background before I get going. So I've served for 23 years in hospice and also in acute care, palliative care in the hospital setting. And chaplaincy, just briefly, in case you don't have a sense of chaplaincy, you're endorsed by your faith group. So I'm endorsed by the Antiochian Archdiocese, and then I provide care. It's mostly across service lines, so maybe pediatric chaplaincy, in my case, palliative care chaplaincy, oncology, etc. And so for me, there's a fundamental understanding that I'm always going to be with people who are not necessarily Orthodox. Mass General has a pretty good amount of Orthodox people who love, to meet me, and we pray together, and it's very cool to be able to share our prayer language, our theology, and to process it in this way that we share. But most of the time I'm with people who are not Orthodox. So for me, first, just to start off by saying context matters. All the setting and the context deeply affect the way that I think about how I'm going to engage the person in front of me in terms of how deeply we may get, what the topics we're talking about. So is it a long-term relationship, or am I going to see this person once? Is it an acute care setting? Is this an ICU setting versus maybe a longer-term hospice setting where I might see someone for a year every week? So these things matter. So it's hard to generalize sometimes. And again, what is my role if I'm in a multi-faith setting versus if I'm in an Orthodox church setting giving a retreat with Orthodox people versus being with people who are very much not grounded in any faith? I approach it differently. Of course, I come from the same place, and I think about my work as being grounded in my faith as an Orthodox Christian. But, just a few notes. I can think of times I had a patient where the patient was Episcopalian, one daughter was pagan, and the other daughter was a Jehovah's Witness. Okay. And then I was asked to officiate a memorial service for the mom. So that was very interesting. And one time I can think of someone I was caring for a patient, and her son was a fundamentalist, I would say, not only evangelical, but also somewhat fundamentalist Christian who was convinced that he needed to save me. And I remember sitting at the kitchen table and he's like, "But don't you want to know that you are saved?" And I was it was not a good time to talk about having been saved, being saved, there was not a lot of nuance, right? So sometimes you have to kind of work with what you know, and sometimes you have time to really expand. Even Christians, though, have often different ways of conceptualizing healing, prayer. How do we think about prayer? How do we think about miracles? How do we interpret scripture? Or even the origin of suffering, right? They say, why is God sending me this horrible cancer? I thought I'm a good person and I don't deserve this, right? That's not really the way that we might conceptualize suffering in the church, right? We think we live in a fallen world. And truthfully, a couple of my Orthodox patients, they say the opposite. Instead of like, I'm a good person, I didn't deserve this, they say things like, well, everyone gets sick eventually. Or they have this kind of lovely resignation about, yes, life is full of suffering. And how do we get through it? Not why did this happen to me, but how do I respond? And so for me, that's really always the framework. Also, now that I'm like a baby researcher, we know that in palliative care patients, spiritual distress is prevalent. In at least half of palliative care patients, a study that we did a big multi-site study using a validated tool, and over 50% of patients were assessed to have moderate or severe spiritual distress. And this is across all religions and no religion. So this matters. So we need to be able to engage the distress of people who are not particularly religious. And also we have this idea of total pain in palliative care: physical pain, social pain, isolation, emotional pain, and spiritual pain. And so often we may see patients who their pain keeps going up and up. They keep giving them more and more medication, but the pain stays the same. It's because they're having other types of pain. So that's my framing of all of this. So here's my case, Harper, I'll call her, who's a 45-year-old transgender female who's Wiccan and an oncology patient. So I met Harper on the oncology unit at Mass General. So the first meeting, Harper came in because she was having symptoms after a major cancer surgery. She was in acute pain. She was wearing a very striking hot pink long wig and the hospital gown in the bed. And so we started chatting, and I said, I'm the chaplain. And oftentimes people, like, they don't even necessarily want to talk to the chaplain. They're suspicious. Like, what? Who called the chaplain? Are you going to convert me? Are you going to judge me? Do you think I'm going to hell? I mean, it's interesting. It's very fraught for many people, oftentimes because they've had sometimes very bad experiences with religion. So I shared at some point, Harper shared that she had actually been raised Wiccan and was from Salem, Mass. And I said, oh, well, I'm Orthodox. And she goes, ooh, I do like the Greeks. I don't really believe in God, but I really like the glitz and glamour of the churches I went to in Greece. Okay. So when you're with someone like this, I want to share my own process, my own inner thought process, and then how I respond. So when you're with someone who has a very different worldview, what I try to do is kind of take a step back and think about ways I can align with them. How can I join with them? So my inner monologue after she said, I like the Greeks and the glitz and the glamour, I'm thinking, I'm not Greek, I'm Irish. Come on. It's not glitz and glamour, it's beauty and wonder and worship. It's not about the gold, it's about God. But I guess, it is beautiful. And maybe it's okay for someone just to be drawn to beauty, right? Like if it makes someone walk into a church, I'm drawn to beauty. What am I drawn to? Am I really drawn to just the glitz and glamour? I wish I was cool enough to wear a pink wig. This is that's happening inside me. And so for me, to respond to this, what I center into is we share an appreciation of beauty in some sense. I appreciate that Harper seems open to cultures and curiosity and interest, and it was actually quite affirming of my sharing that I was Orthodox Christian. So on that visit, what I found is it was superficial, but there were ways we can connect. And also we found a shared love of musical theater, which if you all know me, my other whole career is that I'm a music director in theater. And so there's a lot of quotes and songs that we shared. Okay, the second meeting, Harper was preoccupied that there was a court date coming up related to Harper's partner. So Harper said, my partner died. He was shot, but it wasn't even for him. He was meant for this guy in his building, and it's been almost a year. So Harper is grieving the loss of her partner in a violent death. So inside, I'm thinking, she lost her partner to violence. She's had a horrible loss. He was innocent. She must be devastated. That's awful. I can't relate to this at all. I have not really been around gun violence. I have a nice husband who I get to come home to. I have a family at home. I probably can't relate to anything that she's experiencing, and I don't know what to do to help her. I am different from her, okay? But then when you step back and you think, how can I align with this patient? So first, of course, she's suffering. She is grieving. And if there's one thing that we know we need to do, it's care for the grieving and the suffering. I can, regardless of the setting, the person, the personhood, the gender, whatever, I can have compassion for someone else's experience of loss. Full stop. I can be curious about their experience. I can want to understand their human experience of loss and have an appreciation for how grief is destabilizing to someone, especially in the midst of a very serious cancer diagnosis and treatment process. So again, the alignment there is around compassion, understanding that grief hurts everyone, and wanting to be open about her experience. And thirdly, in the third meeting, Harper was in deep despair. She had realized that she had a change in prognosis after a scan, and she was not available. She was not going to be able to access a trial. She thought maybe there was a chance of more surgery, and it seemed like there was really no more disease-directed treatment, and the focus really was going to be more palliative care and even hospice. And she sat there and she sobbed, and she said, I'm not going to beat this. I don't know what to say. I don't know what to do. What am I doing? I'm not myself. And in that moment, my inner dialogue, my unhinged inner dialogue, this is awful. This is sad. This is a moment of the remembrance of death. Yes, I did think that. I don't really know what it is like to know you are dying. I should. We're supposed to practice the remembrance of death. What is it like for this person? This is her only life, and she has a couple months left. She is unanchored. Her parents are gone. Her partner is dead. I don't really know what she believes in, life cycles or nature. Wiccans, I'm not really sure what Wiccans believe in. I'm thinking of it was Halloween time and it was double, toil and trouble. That's what I was thinking about. I was thinking, what do Wiccans do? And what can I draw on to support her? How can I help her in this moment? And so for me, for someone, there is something very powerful about being with someone who has come face to face with the fact that they are dying. And they know we all sort of know it's happening, but when you know you have a few months left, that is a whole different ballgame. And so for me, I am trying to, having all these complicated thoughts in my head, but I just have to back up. I can start by being here with this person. I can be here and look at her and see her as a person made in the image and likeness of God. So this is not a time to have theological debates or discussion about this and whatnot. She's been given the most devastating news a human person can receive. And so can I provide a safe space to hold her, to let her express what she needs to express? I write down the scripture, be kind to one another, tenderhearted, forgiving one another, as God in Christ forgave you. And the thing is, the only way that I'm able to be here with her or with anyone is because of God. So forgive one another, love one another as Christ loved you. So there's these areas of tension and meaning making. But of course, for me, and I think for many of us, for all of us, thinking about Matthew 25, you visited me when I was in prison, you visited the sick, the hungry, the naked, you clothed me. And so not only is that the right thing to do as a Christian, it's actually our salvation depends on it in Matthew 25. If we care for the sick, the suffering, this is our fundamental call. And I remember a nurse came up to me and she was kind of unkind and she was like, that guy is a bit much. And she was kind of a little bit mean. Also wanted to make it clear that she did not approve of the concept that Harper was transgender and kept calling him a guy. Of course, we have a different theology and a different worldview. She adhered to a mode of gender expression and sexuality that some different worldviews have concerns with, or, certainly isn't, it requires a certain pastoral discernment and wisdom in order to support people like this. And so for me, the human connection is the real piece. Harper is a fellow human in the image and likeness of God. We shared a love of theater. We shared respect for the beauty of the Orthodox Church. And eventually we came to really connect about the concept of cycles, life cycles, liturgical cycles, nature cycles, this idea that life changes and moves. And there's so much instability. And there's so many things that change and fall. The leaves fall to the ground and die. So what do we have to center ourselves when everything is falling apart around us? For me, that's God, right? That is the center and the core of our being. And for Harper, she didn't exactly believe in God, but we did have this sort of very interesting conversation about the cycles of life, of birth and death, cycles where, in winter, everything is sort of dormant, and then where life comes in the spring. It was actually a very interesting conversation. And at the end of the day, Harper was wrestling with, who am I? How am I going to survive? How am I going to manage living as I face my death? And again, in this place of grief, a place of sort of very painful prognostic awareness and fear and numbness and existential suffering. And so again, at the end of the day, for me, there are times, maybe if I got to know Harper for a longer period of time, I might explore some aspects of their personhood, their, religion or lack of religion or reactions against religion. But in that moment, to be able to sit and be present with someone, to listen and to hold that space as a non-judgmental person as much as I can. We have all these judgments in our head. But to be able just to hold that, I'd like to think that's a small way of peacemaking. And, think about the 99 sheep and the one sheep. And I'm not remotely implying I was able to save this person, but for Harper, just in that moment, in those 3 visits, I know that she was able to share something that was very deep and very painful. And I think there's an inherent value in being able to share that with someone who, she might have been afraid that I would come at her with any number of opinions about any number of things. And it's not to say that, I think of all the choices she made or all those kinds of things are fine and dandy, but I also don't know enough about it to make those judgments, and that's not my role right now. Maybe, again, longer-term relationship, you get to know each other more, sure. But in this moment, it's almost like I think of myself as like a paratrooper, just jumping in, and then you have to immediately assess the situation and triage. And for me, the triage was being able to just say, we don't know what's going to happen, but we will be by your side as you navigate this. So, thank you.
Thank you, sir.
All right, and now we meet Angela. A little bit just about the context that I come from. About 29 minutes and away from here on the west side of Chicago, I'm at Lawndale Christian Health Center. So we are uniquely a Christian faith-based health center of about 800 employees, started out of an evangelical church ministry 40 years ago, and we have 70,000 patients that call us their medical home. We're in the 4th year of our very first family medicine residency that we intentionally recruit applicants that reflect the diversity of our community who are also in line with our mission, which is explicitly to show and share the love of Jesus by providing quality, affordable healthcare, blah, blah, blah. Right. So I will say that is my context. That's where I landed for part of my fellowship training, and the Lord has not released me yet. I'm still there, 14 years and counting, and have held a number of roles as a clinical psychologist, being part of the director of behavioral health, and then now I primarily find myself as one of the core faculty in our family medicine residency. So I'm a bit of a unique animal, doing a lot of what OCAMPR does altogether in my workday. So I'll say in our context, I don't have the luxury of doing an hour a week of psychotherapy with my 50 patients on my caseload, like some of you do. I think more of my caseload is the 10 physicians that I work with every day. And I am treating them, helping them figure out how to best treat their panels over time in the longitudinal relationship that family medicine and primary care we know can offer, especially underserved on the west side, where there's not access to specialty care in the way that other communities sometimes do get the benefit from. So a lot of times now when I'm primarily teaching and training, and I'm usually always having a family medicine resident with me in our encounters. So I am now in a situation where I might see 12 different patients in a given day, maybe for 15 to 30 minutes. Maybe one patient I've seen 15 times over the last 5 years. Maybe one I saw during their last pregnancy, one I've never seen before, one I'll never see again, and then another one I just saw last week. It was a quick follow-up. So I have quite a diversity of types of ways in which we are often, love the word as Sarah said, triaging, right? Triaging is definitely the name of our game. So many of the different wars that we can find ourselves in that really, I think, can create such a sense of moral and spiritual injury. How do we provide good, holistic, comprehensive care to the human in front of me in 15 minutes, 20 minutes, maybe 30 minutes, right? If you just really want to get behind on the next 3 people waiting for you. And so I think that is definitely one place in which there's that sense of tension, as well as our health center clearly says Lawndale Christian Health Center. So if somebody's reading and sees that there, they might realize that and think that. They also might think, oh, that's just in the name and the title. Maybe the people that work here are or not Christian. Some people just go there because it's where their neighborhood clinic and we provide good care. Some people go there because their Medicaid card assigned them. Some people go there because their grandmother has been coming to our clinic for 20 years. So people will come with a variety of different backgrounds and assumptions about what's going to happen once they walk in through the door. So I give you that context just to sort of set the stage a little bit for meeting Angela. So she's a 34-year-old Black female. She is reestablishing care with her primary care physician today. Last time she was in was 2 years ago. I actually did see her once back in January back then, and then she's here just this past Tuesday for her second visit with us in quite a while. So I got called in on the case from the primary care physician who was another resident physician. So we're also working with shaping our residents' understandings of how do we treat substance use, mental illness, as well as medical complexity. So the resident was terrified. This patient just had suicidality 3 days ago, and they sent me a message on my chart. So what do? I'm like, well, that's wonderful that you actually scheduled them. You got them in, and they came today. Like, that's already miracle one, right? We're here. And so this patient is coming back in, trying to get back into care. So immediately I already have a set of ideas of what am I doing to bring peace to this situation. Does this patient need to go to the hospital? Are they in the right level of care? Are they interested in starting treatment? What fires might we find as we go behind the door and sort of trying to prep the resident that's going to be with me for that? So you can see here in her problem list, definitely major depressive disorder, recurrent severe PTSD. Over a quarter in our community would qualify for PTSD if they were officially diagnosed. Also seizure disorder, as well as alcohol use disorder. In her case, praise God, in sustained remission. Who has been paying attention in all the addiction lectures we've been having? In sustained remission means for about how long?
6 months.
At least a year or more, right? Yes, at least a year or more. Okay. So, current medications? None. Why is she on no medications? Who can read that parentheses?
She's been in jail.
That's right. Unfortunately, very often in our communities, when folks are released from the criminal justice system, they are not released with their Medicaid card reactivated. They are not released with a bag of all of their medicines that they've been taking every day. They are released with nothing and no discharge transition plan. So,
Sometimes at midnight.
that's right. Not even with a bus card sometimes, unfortunately. So, quite a big disruption in care and did not have the ability to requalify for insurance at that time. So thus she's been 10 months running off of her meds. Past hospitalizations is relevant. 3 psych admissions because of suicidality. The last one was 2 years ago. All right, so as we're gathering some biopsychosocial spiritual history that's relevant, some of her big motivators and supports. Her birthday was the next day, so we were definitely using that. She's now gainfully employed as a cashier. She's got 2 children, and she mentions her wife. Some key stressors and challenges. She's still trying to maintain all of her requirements for probation. She mentioned she recently got reunified with her children, which makes me think, DCFS possibly was involved. Was there an issue with custody? But she did mention that I just got back with my kids now, so that was another flag to me. As we were in the course of the interview, it also came on our radar, likely this patient might have some intellectual challenges. So we're having to customize everything that we're saying, really reduce our complexity, shorten our phrases, and kind of work with her in a little bit different way. So that's another thing that we were navigating. And then we saw in her chart that she was raised Protestant, but no longer is practicing. So what might be some areas of tension? As I say all of those things, if you imagine yourself in your role in an encounter with Angela, what might be some areas of tension that would come up for you?
The suicidality, does that mean a suicide attempt or just suicide ideation?
Yes, thank you. We're getting there. She had, in this current one, she had suicidal ideation with a plan, no behaviors, but her last attempt was with behaviors. She did take pills, and that was 2 years ago.
I'm afraid.
Yes, that is that's a key nuance. Thank you. Absolutely. Any tensions that you all would also be finding yourself with? She had her 3-year-old son in the room, and at times she referred to herself as dad to the child. And so that was my other clue of, okay, you've mentioned wife, that you have a wife, right? But then also you just referred to yourself kind of like she was recounting a story about, what the son was saying. And then, Dad, come over here. And I thought, oh. And I quickly paused and looked at the chart to make sure, oh no, did I misgender her earlier? And I said, no, it wasn't that. So you're sitting in sometimes tensions and wars of how do I, as an Orthodox Christian, as a clinician, hold in tension some of the things and values and choices and beliefs and practices that may or may not be aligned with our faith. And I think
clarify what the perspective was.
The perspective was unclear, and I was not sure in the triage of should I bother clarifying?
Yeah.
Should I proceed to figure out if I'm sending you to the hospital?
Yeah.
And so to the very point, right, it was I only have X amount of time with her and X amount of bandwidth attention span, especially given her intellectual functioning. So what is the greatest harm that I am trying to work to reduce? If I was going to be working with her for an hour a week, every week, 100%. I'm
Figure that out.
SI, and then I'm moving to, and now I noticed you mentioned you called yourself dad. Tell me more, right? Of course we're going there, and we're figuring out that things with the wife, and we're understanding more about her gender identity and sexual orientation so we can know how to navigate that. In the moment, I'm putting that in the parking lot. And I said, well, let's see if we get back to that, but good to know. That's going to still, though, inform how I am navigating the rest of those 18 minutes, though.
You
right?
didn't know I was going to ask. So.
No, this is part of it, right? This is number 2, the area of tension that we had. About a quarter of my day, I would say I probably spend working through barriers, stigma, and challenges around starting antidepressants. Managing suicidality via something other than prayer, forget about it. That's stupid, don't have that thought. Those are usually the most common strategies that families in our community
And which
would prefer.
antidepressant is important?
That's right.
Because some of them will kill you and some will make you sick.
There is a whole wide range of those antidepressants. An analogy I always like to use is it's kind of like trying on jeans. There's a lot of different brands, sizes, models. The type I try on, the type Isabella tries on, they're going to look very different on both of us. It might be the same pair of jeans. Probably looks amazing on her, not good on me. In a certain brand, I might need one size, and a different brand, I might need another, and it's not that different with antidepressants. So just because somebody has a terrible experience on one doesn't mean everybody's going to, and just because one is wonderful for somebody does not mean it's going to look good on everybody. Some other areas of tension. When our patient was incarcerated, she was in a different state that did not have the Affordable Care Act expanded Medicaid, and now she's returning to Illinois now. So now she is eligible for that. So that was another area of tension, part of her disruption in care that's contributing to the current worsening episode, as well as some of the challenges we've identified with the criminal justice system. So depending on what your political, social, theological beliefs are on some of these things, you are going to find yourself caught in a tension of some of these. Can. So what were some paths to peacemaking that we took? For this patient, she has struggled with severe, chronic, persistent suicidality for the vast majority of her life. And she was really struggling with her wife being a huge support to her, and her wife being so concerned and confused as to why she keeps having suicidality. So the 3 days prior that we saw, right, so on a Friday is really when she had the worsening of her suicidality. She told the wife, and the wife responded very well, but then kept really questioning and on her, like, well, aren't you happy? What's wrong? Why are you having this? And really trying to understand the logical reason. And our patient could not quite verbalize or articulate her experience, partly due to some intellectual challenges, but also because of some of the stigma and bias that can come with folks not making peace with some of their chronic mental health conditions. So, one thing that we talked a lot about with her that ended up being a path to peacemaking. We were not selling the gospel of antidepressants. We were also not shaming her for suicidality. What we did is said, you know what? With some of the conditions that you have, with some of the things that you have lived through, I would not be surprised if we might want to think about suicidality almost kind of like a ladder. It will not be surprising to me if you have a ladder that's maybe always in the room with you. We can't just delete or get rid of that ladder. The issue is when you get close enough to the ladder, you need to find yourself, where are you in relationship to the ladder? We might always find in seasons of depression, you might be at the base of that ladder just having those thoughts. What would it be like if I wasn't here? The issue comes when you start taking steps up and find yourself climbing up that ladder, thinking more about, well, what would it be like if I wasn't here? What if I took some pills? Maybe my kid would be better off without me. What happens the higher and higher up you go on a ladder if you fall? The higher you go, the higher the risk, the harder and the greater the harm is going to be if you fall. So moving from an acceptance-based place of, instead of just ignoring, deleting, pretending like we don't have the suicidality, really accepting and acknowledging this might be a part of your ongoing experience. The key is your relationship to it. And when can you notify somebody? When do you need to seek out and get that help? that really resonated with her. And it was a big light bulb moment that she saw. And she realized, because, another clinician had already reviewed, call the crisis hotline number, call or text 988 anytime, night or day. And it was in that moment when I said, and imagine yourself when you're up climbing on this ladder at 2 a.m. and those thoughts about taking the pills are happening again. Are you going to wake up your wife? She was like, right. Could you text 988? She said, yes. Yes, I could. What was that number again? Let me put it in. Right? And you saw that transformation, that move for her. Another key path to peacemaking for her was taking her seizure disorder that she had lived with off and on. She wasn't actively having seizures. Of course, we know not on medication for them. Making that parallel between her seizure disorder as well as her major depressive disorder. She was really wrestling with, how do I explain this suicidality to my wife? Now, I could have gotten very distracted by the idea that we're talking about how to support and promote things with her wife, right? How am I negotiating that as an Orthodox Christian? I'm saying in my triage of harms, that's not today's battle. That's not of greatest consequence. This wife, God used to play a life-saving role in this woman's life 3 days ago. Now is not the time for me to not engage something around the wife. The wife is a key critical intervention today in this moment. Again, in the parking lot, but we are always doing a triage. So as we talked through, I'm curious, thanks for sharing a little bit about, the last 3 days, what's been going on when you had those negative thoughts that you didn't want. I'm curious, the last time you had a seizure, how did your wife respond? And we started walking through that a little bit. And it was in the parallel of that. Eventually we got to a point and all of a sudden her eyes lit up and she went, oh, you mean this is like my seizures? Right. When I have my seizures, who was at fault? And I said, right, what are some of the things that you do that might bring on a seizure? And she says, yeah, when I don't eat, when I go for a long time without water, when I'm out in the sun, when I'm really stressed. Exactly. And then what happens other times when you did all of that well? She's like, yeah, and I still had a seizure. I said, that's right. Sometimes it's not that different with suicidality. Mm-hmm. We know there are certain stressors and things that happen in our life that we can do that can sometimes make suicidality worse or trigger it. And other times it just comes even when we don't want it. And so she said, yes. I said, some of the time, accepting depression as a chronic medical condition, not for everyone, but for certain folks, definitely she would qualify, can be the difference. That can be what moves somebody to a sense of peacemaking, even within her own self, about her own experience. So, lastly, we praised her success with alcohol cessation, really figuring out what helped you to stop using alcohol 2 years ago. What was that change? And she said, because of my health. Because I know I have seizures, so I knew I had to stop drinking because I want to be here for my kids. Well, that's very different from 3 days ago wanting to take pills because they'd be better off without me. And so I said, you seem to keep struggling with the idea of taking and staying on a medication for your depression. If you were willing to stop drinking as the medicine for your seizure disorder, what would it be like to think of taking your depression medicine to be the medicine for your depression? Both of these are going to keep you here healthy and longer for your kids. That was another light bulb moment for her. And that totally moved the needle again. And she went, oh, yes, I could do that then. Because that's why she was there today. That's why she came to the visit. So, as we kind of talk through the takeaways and sort of transition to our broader discussion, I think for me, a big thing to highlight is really whose agenda is it anyway? A lot of times we get caught up in what our culture is saying, or even what the cultures among Christians are saying needs to be our focus, when in reality it's the Spirit of God that sets the agenda. What is the most pressing thing for this patient, for Angela? It was her suicidality. It was her depression. It was not her wife. It was not her being incarcerated. It was not any political topic related to the social determinants of health that brought her there. We have to lay aside what the culture is saying and really focus on what the patient is saying, what their needs and priorities are, and focusing on who is setting the actual agenda. I think also in the line of triaging, thinking about theological harm reduction. Of all the areas of tension and harm that you've heard today that can be present for Angela's life, which is our biggest focus for the day? I have to triage my expectations and my interventions and my outcomes based on the acuity and the risk for harm, not just according to what an Orthodox Christian might believe, because that's not where Angela is coming from. So many times we see through a glass darkly, as Scripture reminds us of, and it is not up to me to determine what might dirty or clean the noose of my patient. And letting the Spirit help us determine and discern which is the thing that's the worst, the best, the first, or the easiest for us to work through. Because we only have limited time and bandwidth for anybody, but especially in our context. And so I think sometimes we can get paralyzed with that sense of concern about our own personal integrity, or what are we doing for the person in front of us, or what are we not doing. So I'm going to pause here so we can continue our discussion.
All right. Thank you so much, Casey. We're not going to walk through all of these, but you can read them. Just, here are just some ideas. When you look at the peacemaking literature, a lot of it is focused on your own heart, your interior, finding inner peace yourself. Some of it is interpersonal, like you see it in marriage therapy, for example, or interpersonal communication styles. And then finally, intergroup, like racial healing, or going into lands where there's been warfare between groups and seeking healing. And I think, different strategies are appropriate for each of these. But, we just wanted to share these things you can look at, but we wanted to open it up for discussion in here. How have you encountered things that are socially divisive in the clinical setting and dealt with it? Have you used any of these strategies? Did they work? Did they not work? What do you struggle with the most? And so we'll open it up right now for discussion.
All right. So my name is Diana Ball. I'm a licensed clinical social worker. I kind of specialize in what I like to, I think my directories always say that I specialize in the clients that other therapists find too hard. So one, I was thinking about I have a client, as you were all speaking, first of all, thank you very much, because I've worked in interdisciplinary settings and good job. Currently I have a, I don't know, kind of mid-30s, intersex, transgender, Jewish convert with DID. So this is fun because I am, dissociative identity disorder. Yeah, sorry.
Yeah, all the wives are whispering to their husbands.
Yeah, I heard that. So, one of the things that keeps coming up with this individual is they were just intensely hurt by Baptist grandparent and hates Christianity. Christianity is evil. And I'm sitting here, no joke, with in the background, it's probably not clear for them, a picture that I took of the inside of a really old church in England. So it's not overtly Christian, but if you really look at it, it's a church, guys. But one of the things that I really focus on with this individual specifically is really pulling out, because I am Christian and Orthodox. Like, I have a really deep respect for the ancient faith practices. And so I'm pulling out, like, well, what does the Torah say? Like, let's talk about David. Let's talk about Moses. Let's talk about, what is your faith practice? What does your rabbi say? And so really trying to focus on gently understanding that individual's perspective of all of the stuff that's going on. But it's really complicated sometimes.
Yes. Thank you.
And just, one comment, I think, when Casey and I were having conversations getting ready for this, imagine if you have young evangelical residents who are struggling with this sort of thing for the first time. Christianity's being attacked. Do they have a moral obligation to defend it, right? Or even defending your own integrity. But I just think, again, of the Gospels and of Christ. I just see it so clearly in everything he says in the Sermon on the Mount, with don't judge. Hiram Gregorius says that is your get out of jail free card. Just don't judge, And of course, we have to make moral judgments. We have to. But judging others, loving others, you can't go wrong with that, right? And that's what I'm hearing you do and hearing the clinicians talking about, trying to find some common ground, some inroad to build the healing relationship, right? I think that's beautiful. So thank you.
So not really a way that I've successfully navigated this, but similar to what you were just saying, I'm a medical student.
Yeah.
Interested in OB-GYN. And luckily I go to Loyola in Chicago, so they're a Catholic Jesuit institution. So it's kind of convenient to be learning in that area, but for residency, I don't know where I'm going to end up. And I think a lot about
family medicine, London Christian Health Center, perhaps.
I actually have a friend who was over there, so. But yeah, I think a lot about what that's going to be like when I'm faced, not just from the patient perspective, because I did trauma support volunteering, so I've been with people in really hard times, and I can be quiet, but with colleagues saying certain things or with my classmates saying certain things, I don't have as much of a struggle with being with patients as much as I have that internal struggle when I go home and I'm like, oh, I feel very helpless about the state of the world. And so I didn't know if you guys had thoughts on that, because that's just the biggest problem I'm facing as a young professional, I guess.
Thank you for sharing that. I hear that. I'm also very aware of our time, so I think we have to wrap up. But I guess one thing I would say is you can always talk to the chaplains. Chaplains are there for everyone in the whole hospital, including staff. Okay. And also, I think, just to have a place where you can process it, right? Whether that's fellow residents or friends or whoever, your church community. And also for now, I think one of the simplest answers is, control what you can control, and what you can't control, you have to learn to navigate. You're navigate in that world. And so, briefly, I felt so awful. I was at a conference in Canada, Montreal last year, and medical aid in dying is legal in all of Canada. And there were all these 3 Coptic physicians that I met last year, and they all came up to me because I'd given a talk about spiritual distress, and they are, basically people are coming and saying they want to have medical aid in dying, and you can always refer to someone else, but you can't do nothing, right? And so this poor guy, he was truly disturbed about, even if you refer to someone else, in a way you are still connecting them with this practice that has become very concerningly prevalent. And in Quebec City, it was 7% of all deaths from medical aid in dying. I mean, it's crazy. It's really a concern. But so again, you do your best to control what you can control, your own responses, your own actions, your words, your peaceful self. to pray that God will guide us in these settings, and to also bring people into our lives who will help us do that. And so I'm sure you'll find mentors and friends who are able to support you in that too. And I'm sure we all have colleagues that, we wrestle with these things a lot, and we are not perfect, and we occasionally screw up or say the wrong thing, but I do think if the intention is there, we still can do this healing work in good faith.
Keep coming to OCAMPR.
Yeah.
You need mentors. You need people who've been there, and don't talk to one person, talk to many people, learn from many people. I think that's key.
Yeah, and so to conclude in that spirit, that scripture that has always been a huge encouragement to me in thinking about how to triage, stages of change, even motivational interviewing. I can't do everything for every person every time to the fullest extent of what I would want. But God has their healing much more in mind than I ever will. And that is not my role. My goal is to discern what is the task for today with my role and my goal. And so I often return to the parable of the sower. So let's conclude with that from St. Matthew. Chapter 13, that same day Jesus went out of the house and sat by the lake. The crowds gathered, and he told them many parables. He said, a farmer went out to sow his seed. As he was gathering the seed, some fell along the path, and the birds came and ate it up. Some fell on the rocky places where it did not have much soil. It sprang up quickly because the soil was shallow. But when the sun came up, the plants were scorched and they withered because they had no root. Other seed fell among the thorns, which grew up and choked the plants. Other seed fell on good soil, where it produced a crop, 160 or 30 times what was sown. God produces the growth. We do not. Our job is to assess the soil. What does the soil need in today's encounter? Sounds easy, and it's very challenging to do, but to continue to coming back to that. I can't produce the growth. That's God's job. Thank you all.